Well, good evening, everyone, and thanks so much for joining us and participating tonight in the Primary Care for All webinar series. It's made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and Clinical Directors Network. Well, it's my pleasure tonight to welcome you to this informative webinar entitled Environmental Determinants of Health for People with Disabilities. It's presented to us tonight by our featured speaker, Bethany Stevens. Bethany is a faculty member and a policy analyst with the Center for Leadership and Disability. Before joining the faculty at Georgia State University, she served as the Center of Excellence for Sexual Health. Let's start over. The Center of Excellence for Sexual Health Scholars under the former Surgeon General, Dr. David Satcher, at the Morehouse School of Medicine. She earned a BA in Art History and a JD at the University of Florida. She earned her MA in Sexuality Studies at San Francisco State University and is a member of the California Bar Association. Tonight's webinar has been approved for 1 hour of Category 1 CE through the American Academy of Family Physicians. Questions for clarification only can be presented to the presenter, can be submitted to the presenter throughout the presentation, but we prefer that you hold your questions and discussion for the end as we have a lot to cover tonight. So we will have an extended question and answer session towards the end. If you do have a question for clarification, then please type it into the Q&A box located at the bottom left-hand corner of your screen. So ladies and gentlemen, with all of that said, please welcome with me, Bethany Stevens.
Thank you. Good evening, everybody. I don't know how to move these poll questions out of the way. Thank you. Okay. So this is my title screen, and I'm going to audio describe the images. This is a way to model access so that when you're thinking about doing your presentations, you're making them accessible to all the people in the room. So this is the title slide for the Center for Leadership and Disability, where I work, and I'll be giving you an overview briefly in a moment. There are four circles on the left-hand side of the screen. The top one is a young man who looks like he's scowling. The second one is a picture of 2 wheelchairs from the wheel floor level. The second circle is circled in red, and it features what looks like an African-American mother and her toddler. And the fourth circle is in yellow, and it features 2 hands holding each other. So this is really just trying to get at branding-wise some of the issues that we tackle, which I will talk about in a moment. And as Sabrina said, that my title is Environmental Determinants of Health of People with Disabilities. And this is my email, bstevens@gsu.edu. And I'm available for all sorts of questions if we can't get to them after this. So this is the disclosure statement. In compliance with the American Academy of Family Physicians guidelines, I hereby declare I do not have any financial or other relationships with the manufacturers of any commercial services discussed in this educational activity. This is the overview. I'm going to give you an introduction of CLD, the Center for Leadership and Disability. We're going to go over the environmental determinants of health through an image, talk about the new disability paradigm within public health, which has been changing over the past few years, give you a few topical areas where we're discussing environmental health, some health outcomes that are basic social epidemiology, and then a period to allow you to ask questions or offer comments. So I'm going to start out with an introduction of CLD, and I don't have a slide for that, so we'll just stick with this one. We are one of 67 university centers of excellence on developmental disabilities in the U.S. and its territories. The objective of these federally funded organizations is to translate research into practice, to create better, more positive systems and social change for people with disabilities and their families. Many of these centers really focus in on intellectual and developmental disability, as our center does, and other centers focus cross-disability, so looking at physical disability, visual impairment, etc. We have had a really prosperous partnership with Morehouse School of Medicine for almost 3 years now, where we have been sharing fellows, the SHLI fellows, as well as the LEND fellows that we have, which is an NCHB funded program called Leadership in Education and Neurodevelopmental Disabilities. And it brings all the allied medical professionals together to talk about disability in new and exciting ways. This partnership with Morehouse School of Medicine has really helped cross-pollinate our bodies of knowledge, in the sense that we're bringing race and ethnicity and cultural competency more into our work and teaching at the Center for Leadership and Disability, and vice versa. Disability is making its way into Morehouse School of Medicine's coursework, including through a class that we co-taught, which is called Race, Ethnicity, Disparity, or Disability and Disparity, excuse me. Moving on to environmental determinants of health. So this is another image that I'm going to audio describe. There's what seems to be a man in a wheelchair sitting at the step or a curb that says prevailing attitudes. There are two gentlemen standing on the sidewalk saying, one says, "Now what's his problem?" The other says, "I can't imagine. It's such a very small step." And so the idea of this image, that I think images really help me create sort of concreteness to ideas that we're not really familiar with. And so this really gets at the idea that environmental determinants of health are both physical and social. So this physical barrier for this individual to access what's on the sidewalk creates a social barrier for that individual as well. And this really just gets at this nexus that physical environment shapes social environment, and these things are very much connected. Quite often when we talk about environmental determinants of health, particularly in public health, we're looking at a lot of biological, chemical, environmental agents that are actually in the physical environment and not talking about social space. So I'm really trying to get that across. So the next slide we will have is the new paradigm of disability in public health. Before I talk about that, I just wanted to give you some brief statistical information about people with disabilities in the United States, because I see that some of y'all are, and I say y'all because I'm living in Atlanta, so some of y'all are, I think you have about 10% of your population that you're serving are people with disabilities. So just so you know, there are about 19% of the population in the US are people with disabilities. Thank you for moving that. And of that population, so that's 54.4 million or so individuals with disabilities. Of that 19%, 10% of those individuals have invisible disabilities, so you may not be aware of the fact that you are working with people with disabilities. And one point that I always like to mention when we're talking about statistics and people with disabilities is that only 1% of people with disabilities are wheelchair users. So while that is the iconic representation of disability, it's really a fallacious representation of disability. So, and I can talk more about that if we want to at the end. So this new paradigm in disability has been documented in Healthy People 2020 and 2010, or I think those are the two. And so it's been expanded in 2020, where we're really trying to get at the fact that disability and health are not mutually exclusive. For so long, there's been this very pervasive idea that if one has a disability, they are therefore not healthy. The Centers for Disease Control and Prevention have been really trying to push this new paradigm through their disability division, and really focusing in on, which the second point is, really focusing in on preventing secondary conditions for people with disabilities instead of primary prevention, which used to be the main focus, i.e. eradication, eraser, and some might say eugenics. Others say that's charged language. Depends on where you sit or stand. And I'm a lawyer, so I may be a little too litigious. So really moving away from primary prevention of disability and focusing on those secondary conditions created through environmental barriers. A really great example is lacking accessible transportation, leading to depression or alcohol and substance abuse because people just are literally stuck in their homes. A third component of the new disability paradigm, as I said, outlined in Healthy People 2010 and expanded in 2020, is that there's this belief that we didn't need a standard definition of disability. Right now in the United States, we have at least 51 different definitions of disabilities operating through Social Security, Medicaid, the census. I mean, they're all over the place. CDC surveys, all sorts of things. They're all over the place. We have no unified definition. And we know as health practitioners how important it is to have a unified definition. So that's what we're calling for, is a unified, universal definition of disability so that we can have a better sense of what the problems, the issues, and what the community looks like around disability. And finally, which is probably most pertinent to this talk, is the recognition that the environment does indeed play a role in disablement. And disablement is basically a fancy term for politically, socially, etc., disenfranchising people with disabilities. So before, we had no recognition that the environment did indeed play a role in this. And perhaps we've seen some changes since the Americans with Disabilities Act came to fruition and promulgated in 1990, and then with the amendments most recently. But we're still struggling to see this environmental issue as really shaping the social and physical lives of people with disabilities. And just if you want an international look at a really great definition that includes this issue of environmentalism impacting people with disabilities, you can look at the Convention on the Rights of Persons with Disabilities, and their definition of disability really nicely encapsulates that issue. Next slide. I'm going to go over some topical areas. I've got 3 to cover. And we're going to look at both physical and social space so you really can get this idea that I'm talking about, that we're not just focusing in on built environments. We're looking at how those environments actually shape our social lives. And I do keep my slides minimal, but I can give you more resources aside from the ones that we see on the notes page here for resources. So housing. With physical issues, we're lacking visitability. This is a key word if you want to do more research on this term. It basically means physical access to residential homes. Because we can see with the Americans with Disabilities Act being implemented that access is trying to be promulgated in all of these public spaces. And the last spaces that are not accessible really are homes. And actually, really fascinatingly, the leader, one of the international leaders of this visitability movement, is a woman by the name of Eleanor Smith, who is a part of Concrete Change, based here in Atlanta. And she basically is positing multiple reasons why visitability is really important. One is that people can actually use the bathroom in their homes. People can visit different individuals if they have disabilities. It allows people to age in place. And then the fiscal reason that everybody loves, that bottom line, it's actually cheaper to make a home accessible than to retrofit it. Additionally, to tie this to public health and our allied medical professionals, the American Association of Public Health has finally recognized this visitability issue as a health issue, not only in the sense of people being people with disabilities being able to access affordable, accessible housing, but also just the issue of being able to move around and how that impacts your health, both physically, emotionally, and socially. The next issue with physical barriers around housing is institutionalization. Right now we have about 2 million people, and I use this word with intention, incarcerated in institutions or nursing homes. Many of those people do not choose to live there, and this reflects a Medicaid bias, funding wise, to institutionalize people with disabilities. The Community Choice Act has been named multiple things and has been up for proposition for a number of years, and I have protested with a group called ADAPT to try to get this bill to come to fruition, where it would allow those Medicaid dollars to be sort of held by people with disabilities, and they get to decide whether they want to live in an institution or not. And Mathematica, the large think tank that does government accountability, looking at fiscal responsibility, has found that in fact it is cheaper to live in homes than in nursing homes. So this comes to the issue of commodification of people with disabilities and how there are many vested interests of people who run institutions to keep us there. In a book called Beyond Ramps that was dated 1998, written by Marta Russell, she discusses how our bodies are actually worth more to the gross national product in an institution bed. At that time in 1998, it was between 60 and 80,000. So you just add with inflation, we're worth more in an institutional bed than in houses, which is just really disgusting. Also, I'd like to point out that with this population of 2 million individuals, it is indeed parallel to the population of people who are incarcerated in jails and prisons. And we do know that disproportionately that affects people of color, people with mental illnesses, and people with other sort of cognitive issues. And in Healthy People 2020, there was a push to move away from aggregate housing of people with disabilities. Also, just before I move away from this topic of institutionalization, I would like to say that I believe it was 2 days ago, can't quite remember, I've been traveling a lot, but the Olmstead Decision celebrated its anniversary. This Olmstead Decision came out of the Supreme Court, went all the way from Georgia to the Supreme Court, and it found that it is a violation of the Americans with Disabilities Act to house people in institutions when they can indeed be housed in their homes. So just something to think about. That court opinion was in 1999. Department of Justice is now just settling with multiple states, including Georgia, so we're getting people out of institutions, but the services have yet to really catch up. So this will be an interesting quandary that we'll see. So socially, what happens with these two issues when we look at the social implications of being lacking visitability or being incarcerated in an institution? With visitability, we have lack of ability to freely move, which is a constitutional right. We have the lack of ability to socialize in different homes. lack of ability to choose where and how we want to live. And of course, this really impacts people's sexual health. I am a sexual health scholar, so just thinking about how that limits space for dating and whatever else individuals want to do with each other. These are really troubling problems that we must tackle. Institutionalization, again, lack of ability to choose where and how one wants to live. Everything in an institution is driven by institutional rules. When you wake up, what you eat. When people come out of institutions, they literally are overwhelmed, so many of them, by the choices that they have. They don't know what to do. Citizen advocates is what they're called, and they're all over the nation, help individuals transition out of institutions and help them learn activities of daily living like using a phone, because they were precluded access to do so in institutions. Excuse me. Also, just again, as a sexologist, a sexual health scholar, sexual and other forms of violence are rampant in these places, in these institutions. And what I find absolutely egregious about this is that so often we're looking and people are using sterilization as a method to protect, and I use air quotes here for those of you who are not sighted, to really get at the idea that it's absolutely a lie that you can protect somebody by sterilizing them. You can't protect them from mental health issues that come from sexual and physical assault, and you certainly can't protect them from STIs or STDs, whichever nomenclature you prefer to use. And also just the sexual issue, I want to speak about that again with regard to institutionalization. In most of these settings, people are not allowed to engage in consensual sexual interaction, and if they do, most of the sort of policy around these sexual interactions is that they must be heterosexual in those limited cases where it is permissible. So now we'll really talk about sexual health. So we'll talk about some physical barriers and then some social barriers once again. So the big one that always comes up when we're talking about examples of lacking accessibility for people with disabilities around sexual health, we talk a lot about lacking accessible mammogram or other examination spaces. So many of the mammogram machines require people to stand up, and many of us cannot do that, and others are too short. The Access Board of the United States was just in Atlanta, Georgia, collecting data on what they want to sort of change around examination equipment and other issues related to that so that they are accessible to all people with disabilities. Another issue that pops up a lot in the literature, as well as anecdotally, just as a person with a disability I am, and talking to my comrades in the movement, it's just that a lot of examination spaces or tables are not accessible. So we may be able to get into the physical space, but once we're there, we're told that other people must lift us on the examination table. As a lawyer, I do understand the liability issues there. Excuse me, but however, it's really lacking cultural competency, I would argue, when people are asked in a gynecological exam to sit in their wheelchair and just spread their legs, or have a friend come do that for them. Generally, gynecological exams are not particularly comfortable for most of us, and so adding that extra burden is rather egregious and a violation of human rights of people with disabilities. So physically, another aspect of access is just the lack of access to bars, churches, any social venue. There are lots of places where people meet other people to sort of create desire and connect intimately or start that process, where many of us are excluded from those spaces. Even when people purport to be inclusive, they're not actually. And I also want to take a minute to note, when we're talking about physical access, I don't just mean physical access for wheelchairs, because as I said, that's only a portion of the population. We're also thinking about access in terms of, is the lighting good enough that people who are speaking as ASL can see each other's hands? Are all of these issues around desire related or necessary to be pushed through eye contact? With some people on the spectrum do not like to engage with eye contact. Also, when we're thinking about people who are not sighted, just thinking about what signs or what gets you into a space, and be thinking about how those spaces are contingent upon visual and other social cues that people all across the spectrum of disabilities don't have access to. Socially, there's a lack of cultural competency with healthcare professionals. So what happens quite often, and this is expressed in the literature and Healthy People 2010, and I think it may be in 2020 as well, it's just this idea that we often, as health professionals, tend to focus solely on people's disabilities. So for example, I have osteogenesis imperfecta, which is a brittle bone disease. You probably know this since you're doctors and other allied medical professionals. But so I'm assumed to only need orthopedists instead of the whole range of healthcare. And this is true across the board, that people with traumatic brain injuries are assumed to only need neurologists. You know, people who are hearing impaired are only supposed to see audiologists. It's just, it's fascinating and disgusting that in many spaces we're just not asked sexual histories if we do go to gynecological care or other sexual health care. We're not asked sexual histories. We're not asked if we need any kind of preventative care. And this really gets at the issue of lack of respect of people with disabilities and the pervasiveness of paternalism. The assumption that if we are disabled, we're of course not engaging in any sexual activity, which is a lie. And if we are, you know, our disabilities somehow are protecting us from any sexual health repercussions that can come through just engaging in sexuality, which is really, again, repugnant. And I believe this all stems from, and I've written about this in a few articles, that it really stems from the history of eugenics that has plagued our country. And we often don't admit that this was a United States product, but eugenics was indeed promulgated here, and California was actually the first to initiate eugenics legislation, and that legislation served as the foundation for the T4 project, which was the Nazi project, where people with disabilities were systematically eradicated. In the United States, I think we had, I can't remember the number off the top of my head. Paul Lombardo is a great scholar at Georgia State University who has written about the Buck v. Bell case around eugenics, which was a 1920 case, which made it constitutional to sterilize people with disabilities. That remains legal, whereas you may not sterilize criminals. That has been made unconstitutional. One note of interest before I move on, you can tell I have a very strong interest, actually there are going to be two notes, a very strong interest in eugenics, is that this was an issue that we can see as a coalitional politic issue, and this has just come up in the news recently nationally, with regard to reparations in North Carolina. North Carolina was one of the most aggressive states in its eugenic program. I think they went after at least 50 to 70,000 people, or maybe that's the national number, so I encourage you to check this data. But the point is, with the coalitional politic idea, is that throughout the nation, it wasn't just people with disabilities that were targeted. It included people of color, poor people, and other sort of people that were not deemed viable citizens, and that's in air quotes. So the label of feeble-mindedness or disability was imposed on people that we wanted to sterilize so they would not reproduce. And in North Carolina, they just decided after numerous years that they're not going to give any reparations. And they were talking about something around $10,000 to pay people for their reproductive rights being stolen from them. So that just popped up in the news this week. And my final point about eugenics is that it's still happening in the United States with the Ashley X case, and that has, where basically her breast buds, her uterus, and her appendix were removed, and she's been placed on high levels of estrogen to keep her little and sterile. Little so she's easier to care for, and sterile so that she's, again, quote, protected from STDs or other sexual violations. So that surgery was deemed ethical. It happened in Seattle and Washington State, and it's happened to, I think, 10 other people since 2006 in the United States. We also have this happening in Australia and in the United Kingdom. So this is continuing to happen to people with disabilities. Going on to the next issue. So education. This is a huge issue for people with disabilities, that we have a lack of physical and intellectual access in educational settings. So we have no universal design. So for example, this particular webinar, and all webinars really, are not universally designed in the sense that they're not engaged in using multiple modalities of teaching where it's interactive. This is really dependent on people being able to hear. And I'm not chastising this group, obviously. This is a pervasive issue with web teaching as well as in-person teaching, that we haven't figured out a way to teach to various kinds of minds. And it's something that I work on as a professor at Georgia State, and it's something that I struggle with, but it's a good struggle that I encourage you all to think about. And even within clinical settings, when we're talking about people's diagnoses, etc., just trying to break apart that information and making it sort of universally understood. With people with intellectual disabilities, pictures help, and breaking concepts down. I know that we have very little time for parent or patient-client interaction, but if slowing down and just talking to individuals as though they didn't go to med school, because many of us didn't, it's very useful for all sorts of learners, all sorts of different minds. And then the bigger issue here, or another issue, is segregation. So people with disabilities are segregated in special education settings. And we call this special education, and I really want you to think about how special, even though it is one of part of the big data sets, special healthcare needs, or children with special healthcare needs. I want you to think about how special that particular word is, a lingual, a verbiage ghetto, as well as a way to create a spatial ghetto for people with disabilities. In these settings, there is an incredibly lower standard of education. I spent 1 year in special ed in the 3rd grade, and it was like being in kindergarten again. So not only are these individuals denied adequate education, which is, again, a right that is guaranteed through the Individuals with Disabilities Education Act. We're not getting, many of us are not getting standard education or good education. I was just in an individualized education plan meeting where I was advocating on behalf of somebody with my disability. And apparently I learned in Savannah that it is pretty normative to segregate people who are brittle based on the idea of protecting us from fractures. And so that, you know, it's close to my heart because it easily could have been me. But more than that, it's all of my brothers and sisters who are not getting adequate education, and then they're not getting high school diplomas. And so they don't have access to higher education. And this increasingly is becoming a problem for youth of color, African Americans and Latinas, because they're being labeled with behavioral issues and thrown in the special education track. And I see this as either, you know, a poverty or a prison pipeline. And I'm not the only one. You can, again, Google the resource for that. So this socially, what does this do with regard to segregation and lacking physical or intellectual access and education? Well, one thing is that we're lacking education around disability culture and identity within all public school curriculum. And again, this is going to sound a little charged for a medical audience, but you know, just remember my background as a lawyer and a scholar in sexuality is that this really colonizes people's minds about non-disabled supremacy. And I'm actually borrowing from an African-American scholar, Bell Hooks, when I talk about this. And we're really, it teaches people that we aren't part of history, even though we have made history. The 504 sit-in, which happened in San Francisco, is the longest sit-in recorded in history. And the Black Panther Party helped us, or helped them in the 1970s, bringing them food and supporting them. But where is that when you look at high school or any college curriculum, unless you're in a disability studies course? And then, of course, this lack of social inclusion with segregation, it basically teaches us a lack of self-determination skills in the sense we don't have a sense of agency. We aren't taught that we can say yes, we can say no. We have the capacity to want and to need and express those issues. And for many of us, even when we're mainstreamed, because of lack of social inclusion, which I did experience, and many people who grew up with disabilities have experienced, it leads to delayed adolescence, to where people are sort of, you know, growing up at a later age in their life because they've been treated, or we've been treated, like children so frequently. This is called in the literature, particularly around people with intellectual disabilities, the quote, perpetual child syndrome. And that phrase came about in, I think, the 80s, and we've been using it still. And very problematic idea. So I've got a few more slides for you, and then we will go to questions. So of course, this all is basic social epi. I have my students read this because for some reason, many of my students, be they privileged or not, somehow think discrimination isn't real and it doesn't have embodied consequences. So I like to use Nancy Krieger and other social epidemiologists to really shore up that indeed these issues do create physical, emotional, and spiritual and social consequences, negative consequences, to be clear. A few of these that we can see or that we have data on is that with discrimination, we see higher rates of hypertension, depression, high blood pressure, increased drug and alcohol use, and a whole myriad of other issues that we haven't really studied. And with a lot of this social epi, there's been a lot of focus on race and ethnicity, that is absolutely important. Increasingly, a focus on LGBT, lesbian, gay, bisexual, and transgender individuals and how discrimination impacts their holistic health. We don't have enough data specifically around disability, but it is increasingly coming up in the social epi work. But indeed, we can extrapolate many of these ideas to people with disabilities experience. And you can see it in, there are pieces there to support this. So all of this negative consequences really does speak to the need that we should have greater awareness and inclusion of people with disabilities. I also think it would be really wonderful if on the boards to become a medical doctor, if disability and sexual health were included, because I know as a person who took the bar exam to become a lawyer, if it's on the bar, it's in my brain. It's been pounded into my brain. So moving on. I'm going to give you a take-home exercise, and this is something you can think about. You may not really engage with it too much, but I think it'll be useful if you move on with your life and try to apply this. So just analyze one day of your life and think specifically about access issues, the ones that I've talked about. How much of your life is guided by vision, looking at signs, hearing visual cues to go different places, where there are steps and where, if there is a ramp, various things. Just think about access issues in your environment and think about how people with disabilities would be able to access a day in your life. This is not an opportunity, please don't take it as an opportunity to focus on one disability or pretend you have a disability. This is a practice that some people use where they use blindfolds and they think that that gets at the real disability experience. It doesn't at all. It doesn't really give you the full effect. It just gives you a cursory physical experience that does not give you the experience of oppression. So instead, I really would just like you to observe accessibility and inaccessibility all around you. And I don't have a slide for this, but I do want to give you a take-home point, and then we'll go to questions. Aside from this exercise, I really encourage you to start thinking about cultural competency, and I've been working with people at Morehouse School of Medicine to have their model of crash cultural competency to be disability inclusive. But what's really interesting is if we use disability as a baseline for cultural competency, because we are a community that intersects with every aspect of society, every race, class, gender, political, social affiliation, sexual orientation, we're basically in every segment of society. If people were to be truly inclusive with their outreach, with their clinical services, with everything they do, their public health interventions, anything you're doing, if you're thinking about disability as a baseline of inclusion, you're necessarily being inclusive of all these different identities, and you're really thinking about systems of power, how they're interlocking, how racism, homophobia, transphobia, ableism, which is the power system around disability, and capitalism, how all of these things work together. And so if we think about cultural competency in this radical new way, I think that it opens up a lot of doors for thought that needs to be, and conversations that need to be had. And some of those are difficult dialogues. And I know my journey of learning about racism and white privilege and all of these things have not been particularly comfortable, but I think it's those places that when we're not comfortable that we learn some of the best lessons about life and about how to treat each other and about how to engage in our professional existence. So with that, I say thank you, and questions or comments are welcome now.
Wow, Bethany, thank you. It was a very
Anybody have a question?
Passionate and informative webinar. Can you hear me?
Thank you. Yes, I can. Thank you very much.
I do have a question. Where do we start as clinicians listening to this? You know, of course, my awareness has now been raised because, you know, and it's the whole gamut from how do I define disability, because automatically the first thing I think about is physical, but you've raised my awareness to see
Right.
to see more of what's really there. So what would be your advice, you know, of how do we start as clinicians? Is that it? Like open your eyes and look around, or what would you say would be steps we should take?
Well, there are some resources that we have here, and a lot of those are, a few of those are sexual health focused. The University of Illinois Sexual Consortium is really a lot about intellectual disability. Disability.gov is a good resource to just start thinking about disability. I would just recommend anybody who is doing work with any population that you don't know about to read about it. Like, just engage with Google a little bit. And I think that this gets at the idea again with cultural competency, because, you know, it's not an African American person's job to teach me how to be competent in my discussion with them or my treatment of them if I was a clinician. It's my role as a clinician, or I'm placing myself in the doctor position, which I'm not, but the responsibility is on individuals to learn about different facets of different identities. And I think these resources are good launching points. And just looking at, I think what's really good are first-person narratives from people with disabilities, just so you can get an idea of what we're actually talking about. Because just like other marginalized people throughout history, our history has been told by other people, and it's been shaped by other people in this way that we haven't had control. We've been objects of research, and that has been changing to where we're moving into being subjects and active agents, and looking at participatory action research around disability is a great way to start thinking about how you can interact with people with disabilities within your clinical settings, also research, but just be thinking about how we are useful citizens. And I think that that's a really radical mind shift for most people. But if basic information, if you want it, would be looking at the Convention on the Rights of Persons with Disabilities. Definitely would recommend that. And the UN facts around disability. The World Health Organization this year just released its first disability report. It's huge, but the executive summary would get at a lot of issues that you might want to learn about. And both Healthy People 2010 and 2020 talk a lot about disability, so you can get some basic information there. And just of note, in Healthy People 2020, there's been a push for more classes in public health and allied medical professional classes that'll be disability-centric, using that new disability paradigm. And then just another point that I would encourage people to think about is just like other isms. Again, it's not just the marginalized person's job to stop the oppression. So if you hear somebody using like, for example, the R word, which I will say it once, and it's something that I don't use, retard. Um, when you hear somebody say that, you can also say that that is inappropriate, ableist, and oppressive. Just like I can say that when somebody's using the N word, that doesn't need to be in this space, and stop the racist BS. Sorry for my pejorative, my initial for BS, but those are my initials. But I think those are some things to just really be thinking about, educating yourself, and also just listening to patients. I think that really helps if you take the time to just listen to people. It's amazing what you'll learn.
Wow. I mean, that's
Anybody else
very,
have a
very good
question?
advice. Very good advice. Hopefully we have some more coming through.
Thank you.
Wow. Thank you also too for your passion and for the, I won't call it a fight, but I know you won't be offended by the word fight. Since that you are an attorney. So I do appreciate though, because many of the things that you
Yeah.
reference when you look at some of the struggles that minorities have come through in this country, a lot of the change has come through the fight. Someone had to stand up and say no more, and you got to do differently, and that's what has made people be different and do differently. So I really do thank you for your passion and for your commitment. I just have different eyes today, so thank you.
Thank you. Well, thank you. And your comment, it it makes a point about how much all of these social movements have been really important to so many different communities, and how all these different social movements build on each other's skills. So, when we have chained ourselves to buses and taken over the Senate and the House, a lot of those things have their roots in peaceful civil disobedience from the civil rights movement. So there's a lot of overlap there, and this is something that I'm very passionate about, and I would love to see this flourish more. We definitely need to be talking about disability, because frankly, we're your clients. I mean, if medical professionals don't know enough about disability, who can we expect to know about disability?
Very true. Very, very true.
So,
Well, if there are no questions that
well,
have come
thank
in, then
you.
I want to thank you again, Bethany, for this presentation. Very, very informative. And again, I personally appreciate your passion. And to our audience, thank you for your attendance. I hope that it was informative for you as well. And please also take note that Bethany did offer that she's willing to be contacted if you guys have any questions or need help along the way. You guys can contact me for her contact information, unless Bethany, you'd like to put it up, to type it into a announcement pod to put it on the screen. In the meantime, I'd like to also thank our e-learning and IT extraordinaire, Mr. Quallen Hare. As I always say, sir, I could not do this without you, and we both know the results when I have tried. So again, the Primary Care for All webinar series is made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and Clinical Directors Network. This partnership allows us here at PrimaryCareForAll.org to serve as a resource for you, the clinicians of the National Health Service Corps. Direct financial support for this webinar series was made possible through the U.S. Department of Health and Human Services, HRSA, and the Bureau of Clinician and Recruitment and Services. PrimaryCareForAll.org is funded under a cooperative agreement with HHS, HRSA, and BCRS. This presentation was recorded and will be on the site in the on-demand section. Please visit the website share section for disability resources that'll be found under cultural competency and professional development. Also, please see the calendar for the upcoming July events. And I don't think that I will talk to you guys before the holidays, so please have a safe and happy 4th of July. And the last thing, the CE quiz tab should be popping up as we speak. Please complete it in its entirety in order to receive your 1 hour of a CE credit through AAFP. Thanks again, everyone, and have a great evening.